Welcome to the SPRT Therapy Podcast, where top athletes and doctors share the secrets to moving better, recovering better, and performing better.
I'm going to tell you right now, if it wasn't for Tim Brown, I would never walked again or surfed.
Now let's dive in with your hosts, Dr. Tim Brown and Dr. John Pecora.
Hello to everyone that's on tonight. Thanks so much for joining us for the SPRT Therapy Podcast. I'm Dr. John Pecora.
I'm Dr. Tim Brown.
And we're excited.
Tom Michaud, yeah.
Dr. Tom,
sorry, that
we're
was
excited.
Anticlimactic after that one, Tim. Thank you.
Yeah. Well, we're excited to have you on tonight, Tom. You're a sports rehab legend and product innovator. And Tom will be speaking tonight about his recent paper, Exercise Interventions for the Management of Tendinopathy. How you doing tonight, Tom?
Pretty good, thanks. Thanks for asking.
Good.
Better than Morgan Carg, I can tell you that much.
Well, it's the same conversation. We'd apologize for the late call because you're on East Coast time, but you let us know that you recently retired, so you said it doesn't really matter.
Yeah, I used to get home from work at 10 o'clock at night by the time I finished my paperwork, so this is pretty typical. So, yeah, it's not a problem.
Well, we were doing an educational module last week for Web Exercises Academy on the paper that you'll be discussing, and I think you mentioned at one point you weren't exactly sure what day it was.
That's the beauty. I just got to remember what day is garbage day now. Life is very different when you're retired. I just sit, read, I play sports, I exercise, and it's good. Probably the life Tim has had for the last 40 years.
I don't know about that, but that's the model anyways.
It's been working for you.
It sounds like you're even right. It sounds like you're even busier than you were before you retired. So
I think I was telling you, I used to be, when I would leave for work for a long day, I would be doing something in the morning. And I'd think, oh, if I could just spend another couple of hours reading and writing, like I would just be in the middle of starting something. And then you'd go to work all day and then you'd come home and you were exhausted. So then you'd have to wait for weekends to start catching up on the stuff you wanted to do. That's why I feel bad for you guys. We're all like working full time. You got kids. I vaguely remember that, but it's nice when you can really focus for long periods of time just on doing stuff you love. So, and I love this information, always have. I just find it fascinating.
Right. Well, and weekends, good luck, right? I mean, you always have the best of intentions. You're going to get all this stuff done, and it's especially with having kids, you know how that goes. So.
Yeah, you're doing a good job, so keep it up.
Yeah, you guys too. And just a heads up for any Kairos PTs, ATs, health and fitness professionals out there who'd like to get online CEs for listening to a more in-depth version of Tom's talk tonight, please visit webexercisesacademy.com, and you can get CEs for the module that you'll be watching tonight. And while we're on the topic of the East Coast, you're in Boston, correct?
Correct.
Great. And we were going to talk about the pretty epic hockey game last week in your neighborhood. I think we have some listeners from Canada on tonight, so congratulations. And the NHL got that one right. But before we get started, just a brief rundown for everyone as far as the conversation tonight. Tom will be discussing his background a little bit, and then he's going to talk about the important findings in the world of tendinopathy, injuries, and rehab that he's been working on. And then Dr. Tim Brown will briefly discuss his SPRT therapy principles and how Tom's work fits perfectly into the SPRT model of, number one, improving tissue quality first, then improving movement patterns with functional taping, and then the importance of movement and exercise interventions to reconnect the neuromyofascial system. So just a reminder for anyone who hasn't been on the last couple conversations last week, we spoke with Dr. Eric Goodman from Foundation Training, where he discussed helping elite athletes, musicians, and celebrities with their innovative movement system. So Tim and I will actually be going to Melbourne, Florida, March 8th and 9th for a collaborative hands-on level 1 SPRT therapy and foundation training course, where Tim will be teaching his unique, comfortable, but powerful soft tissue and manual therapy techniques, as well as his functional taping that was created in the 80s while he was the founding medical director for the AVP Pro Beach Volleyball Tour. Let me let a few more people in here. And then Dr. Eric will be demonstrating the concepts and principles of foundation training. So we hope to see you there. And if anyone ever has any questions about upcoming courses or anything that we discuss, please email us at jp@sprttherapy.com. Once again, jp@sprttherapy.com. And we'll be recording the conversation tonight, so this will be available in the future. So if you know anyone who wanted to be here tonight, couldn't make it, was past their bedtime, or they're still working, please let them know that this conversation will be available on Apple, Spotify, and our YouTube channel by the end of the week. Just a reminder to please keep your mics muted and your cameras off until the end. We're going to have Tim and Tom answer questions. So if you have a question along the way, please type it in the chat, and then we'll get to that at the end. And if we're talking or answering your question, you can jump on camera if you feel like it, and be kind of a part of the conversation. Also wanted to acknowledge a few who were on tonight. Dr. Kelly Lang. Kelly, if you want to jump on real quick, if you don't mind. Kelly's an amazing sports chiro. She was a former president of the American Chiropractic Association Sports Council. And at one point, Kelly, are you there? At one point, we were putting
Yes, hi.
At one point, we were putting the pro sport speakers together for the pro sport seminar that happens every year in Las Vegas in December. And I asked Kelly at one point who was on her Mount Rushmore of speakers that she'd want to see. And she said Tim Brown, and then she said Tom Michaud.
Hey,
so
that's nice, Kelly.
Wow. Honored.
That's a mistake. She won't be saying that after this lecture.
No way. These are the shoulders that we're all standing on, right? The giants, as they say.
Yep.
Oh, you're sweet. Thanks. Right back at
Thank you, Kelly. For sure, Kelly. It's just unbelievable.
Thanks, Kelly. And we were going to have a conversation with Steve Capobianco Dr. Steve Capobianco from Rock Tape. He's one of the co-founders of Rock Tape. They've been a long-time supporter of SPRT and now our live courses. And so if you're ever looking for the highest quality kinesiology tape and innovative movement tools and technology with a company that really has a long-standing culture of education and supporting the health and fitness community, please check out Rock Tape. Hopefully Steve will be on here at some point. We know he's extremely busy. And we also have some students and international guests on tonight, as well as numerous professions from physical therapists to chiros to osteopaths to sports massage therapists. I see a few acupuncturists, strength coaches, and athletes as well. So welcome, and look forward to everyone's input and questions at the end. And so to kick this off and get it started, Tom, would you mind maybe sharing a little bit about your background? And then from there, if you want to throw up your presentation and
Sure.
discuss your paper.
Sure. I graduated from Western States Chiropractic College, which is now University of Western States, a long time ago, 82. A great school, loved it a lot of great students, a lot of great professors. Mike Carn was there. He was the best anatomy teacher I ever had. I was fortunate. I grew up in the orthotic industry. My mom was the first employee of Langer Labs a long time ago. So I grew up, and she ended up going up the ranks there. My brother was in charge of production there. So I grew up in the orthotic industry when I was young, and I always loved chiropractic. So even though I was thinking about becoming a podiatrist, I ended up becoming a chiropractor just because I had so many positive experiences myself when I was young. And then when I got out, I started, because I had a specialty in lower extremity biomechanics from working at Langer's, I ended up seeing a lot of distance runners, right off the bat, people like Joan Benoit, the gold medalist in the LA Marathon, and just countless marathon runners. And within a year or two of me being in practice, I really had just a very busy sports practice, which I loved. And in the mid-90s, I wrote a book called Foot Orthoses and Other Forms of Conservative Foot Care, which I published with Williams and Wilkins. That ended up doing really well. I went into 4 languages, which was nice. But again, I don't like public speaking, so I didn't get out to push it a lot. But it got such good reviews, especially in podiatry school and physical therapy schools. I used to lecture at Mass General's PT program. Joanna Brooks was there for a while, just really nice people. Then in 2012, I wrote Human Locomotion, the conservative management of gait-related disorders. And that was a lot of fun. I think there were 2,000 references in it, 450 illustrations. While working full-time, now that I'm retired, or mostly retired, I have no idea how I was able to work full-time and do all of that. But again, I just love this stuff. I find it fascinating. So that brings us up to present day, which is right here. And this article that I have up, and I'm going to do share screen. And here we go. So this is an open access article. I wrote this paper over the last 3 or 4 months. It came out in Journal of Contemporary Chiropractic, which is run by Parker. Great journal. Great. Sign up if you haven't checked it out. It's open access, all the papers, and a wonderful bunch of people. Dana Lawrence is the editor of it. He used to be the editor of JMPT. And they did a really nice job kind of getting a bunch of different subjects out. I wrote an article on obturator internus tendinopathy a little while ago, but this one I wanted to do a review of the literature on exercise interventions for the management of tendinopathy. And I didn't focus on shockwave, cold laser, any of that stuff. I just wanted to do exercise interventions. And again, it just came out January 2025. And the first thing I want to talk about is just what goes on with tendons. 30% of all overuse injuries are tendinopathies, and there's a reason for that. The Achilles tendon by itself can tolerate up to 12 times body weight, yet it's flexible enough to store and return 90% of the energy that it takes to stretch it. And at the bottom in red there's a highlight. That's a paper by Boson Moeller, who's just a phenomenal researcher, and he pointed out that the Achilles tendon is close to operating at its failure rate when people are doing jumping sports. It's under that much stress. So it's not surprising that 30% of all overuse injuries are for tendon injuries, but the Achilles tendon of all tendons is the most prone to injury. And then this is an interesting little slide, which a lot of people don't know about. They kind of think that all tendons are the same. But if you look at proximal and distal tendons, whether it's above the knee, below the knee, above the elbow, below the elbow, if you go below towards the distal tendons, if you look at that picture on the far right, the distal tendons are extremely long and their muscle bellies are relatively short compared to the tendon length. And then if you look at proximal, like glute medius, piriformis on that lower left, those tendons are short. The force generated by the muscle gets immediately transmitted into the bone to create motion. And tendons are broken down into 2 types, positional tendons and energy storing tendons. The energy storing tendons are located below the knee, and they're the ones that can lengthen up to 11% to store and return energy. Positional tendons only lengthen 2%, so they have a limited ability to store and return energy, but they maximize force output. That movement, 11% on that right side of that screen, is important because that degree of separation brings you close to the failure rate of a tendon. And when we're prescribing exercises, which I'll get to later on, it's really important to kind of keep that elongation when you're prescribing exercise, you're prescribing weight to a certain, like a 6.2, 6.4% elongation. But this breaks down into a tendon is made of fascicles, which is divided into fibers, which is divided into fibrils. And this is an interesting slide. Okay, so in this slide, this just breaks the Achilles tendon down into the 3 separate areas because they behave differently. If you look at the graph on the right, the blue section is the proximal portion of the Achilles tendon, how much it stretches when exposed to a pulling force. And it stretches a lot. The middle portion of the tendon becomes more rigid, and the lower portion of it, the tendon bone junction, is extremely stiff and inflexible. This is important because when you get a pulling force from a rapid contraction of gastroc, soleus, mediolateral gastroc, that force is dampened at the proximal portion. And if that section isn't soft and flexible, you're going to get tears at the muscle tendon junction. So people tend to think of the tendon as being one unit that pulls and lengthens in synchrony, but it's 3 completely different sections with variable elasticity. And now force transmission through muscles and tendons. This picture on the left is, it describes the muscles themselves have spanning myofibers that are responsible for longitudinal force transmission. That means they run vertically, the muscle fiber goes to the tendon fiber, and movement of one creates movement of another. But muscles also have non-spanning myofibers that people don't talk that much about. And the myofibrils don't run the full length to go into the tendon. They go sidewards, they attach to neighboring sections, they don't go the full length, and that creates lateral force transmission. It basically just distributes the force generated by a muscle through a broader area. And most of the force when you fire a muscle goes into lateral force transmission, which is interesting. And then I'll get into actin and myosin in a little while. But this is when we get into the tendon component that I find fascinating. The muscles have fibers that shift laterally, they go up and down, but tendon fascicles are all uniform, they all go vertically, and they don't attach sideways, they just go straight up and down, and whatever muscle fibers attached to them just pull on those individual fibers. And that plays a huge role in tendinopathy, which I'll get into in a second, because tendon fascicles largely act independent. So, and again, I put all the references, if you want to look up the original ones, on the slides, which John will make sure you guys have access to these. And this is where we get the elasticity coming from in the tendon. You look at the fascicle fibril, there's a fibril subunit, and then collagen molecules have a triple helix with proline, glycine, hydroxyproline, and they have variable combinations which give them different degrees of stretch absorptions, how far they can stretch before failure. So it's really important that that triple helix be arranged in such a way, because that's what gives the give to the tendon, and that's what gives the ability to restore and return energy, which is so key. And now I like this paper. This illustration took me a while to put together because not everybody, but most people know the Achilles tendon before it attaches, it rotates 90 degrees so the tendon can store and return energy like a spring. Tibialis posterior tendon does the same thing. It goes 45 degrees. Rectus femoris rotates the proximal portion before it springs. But if you look at the individual fibers, that lateral gastroc, soleus, medial gastroc on that bottom picture, the fibers of medial gastroc rotate only 28 degrees before they attach to the Achilles tendon. The lateral gastrocnemius and soleus rotate 136 and 129 degrees respectively. That's a huge difference, and this is why it's important. Remember, with lateral force transmission, when medial gastroc fires, it actually has a straighter line of approach, so there's no delay in the rate of force development before it creates movement. That's why medial and lateral gastroc, even though they're two heads of the same muscle, they behave very differently. When you're during static stance, when I was talking to John about it before, when you are standing up, just balancing, your central nervous system basically keeps you on the verge of a fall. Your central nervous system senses where you are in space. You lock your hips through the Y ligament of Bigelow, your knees are extended, and then you lean forward, and then just your medial gastroc brings you back, not the lateral gastroc. The medial gastroc is the postural muscle, and it's able to accomplish this because its fibers don't rotate. They only rotate 28 degrees, so they're able to put a direct force right into that tendon. It also explains why medial gastroc is injured. I play a lot of tennis. Margaret Karg is out there listening. She plays a lot of tennis. Tennis player's leg is when you tear the medial gastroc's attachment to the Achilles tendon. And then that happens because of the speed that muscle can generate force. And because it can generate force so fast, it has a tendency to tighten. There are different degrees of tightness between the medial and lateral gastroc, and they do different things. I use in my office a series of infrared spectroscopy sensors called MOXIE sensors. I put them on the medial and lateral gastroc and have people do different exercises, toe in, heel raise, toe out. And I want to see firing patterns between those two muscles because they are very, very different in their action. And if you look at that picture on the side, you can see the 90-degree rotation. So if you look at this picture right here, the three little pie-shaped pieces, soleus at the upper portion is in the anterior aspect, but it's on the right side. So that anterior insertion, which plays a huge role with Achilles insertional tendinopathies, that anterior insertion is often the result from soleus and gastroc. And this next slide shows there's 3 types of insertions and for the Achilles tendon. And in type 3, lateral gastroc, and type 2, lateral gastroc is the primary anterior component, which means that in insertional Achilles tendinopathy, it tends to occur at the insertion of the lateral gastroc. In type 1, which is 48%, it can be soleus or lateral gastroc. And it just shows you when you're palpating, you've got to keep in mind where these muscles are going, what they're doing, and what actions they'll have, because that determines what exercises you give during rehab. And now I like this. This was a researcher at Brown, Roberts. They put strain gauges in the gastrocnemius and muscle and in the Achilles tendon in turkeys, and then put them on a treadmill, which I wanted to find photographs of them doing it or even a little video, but I couldn't. So I got this image. And what they found was, and I always liked this because it shows how muscles and tendons work together, especially the distal ones. When a turkey or a person is just about to go into its propulsive period, the muscles, the gastroc and soleus combination suddenly stop just before you hit peak tension, and they isometrically lock down. It's metabolically more efficient to do an isometric contraction. And by freezing at that point, it causes the Achilles tendon to stretch and then returns that energy in the form of elastic recoil. That is responsible for 60% of the work done by the muscle tendon junction. Timing is key. And I'm bringing this up because when you're designing rehab programs, you have to eventually include plyometric drills, because plyometrics teach you to isometrically lock down and let your tendon store and return energy. Before doing those, you have to make sure the tendon is capable of storing and returning energy. So the next slide goes into different reasons that you can have tendon injuries. One of them is if the tendon stiffens. So if you look at the picture on the left here, you see the arrows through the Achilles tendon. People with diabetes, people with different metabolic disorders can get extreme stiffness where they lay down advanced glycation end products. These cause the tendon fibers to tighten on each other and can limit movement. And that creates problems as people get older. They have impaired efficiency while walking. The metabolic cost of walking goes up. And when the tendon tightens, the risk of muscle strain skyrockets. If the tendon is loose, especially that proximal portion, it'll dampen load that would be going into the gastrocnemius. However, when that tendon is tight, especially in diabetics, it pulls on the gastroc soleus. So this is a paper that I put up. Again, you can get the paper. It just came out in 2024. It's called Minute Oscillating Stretching Techniques. Crazy simple. You just take a black TheraBand or any elastic band, and in this study, they had people go from slight dorsiflexion to slight plantar flexion. They put a metronome on 60 cycles per second, and they just moved in time with the metronome. They did that for a minute 5 times. That simple protocol, it increased step length, it increased ankle range of motion, and it reduced the energy cost of locomotion in diabetics. The prevalence of diabetes is skyrocketing. This is a simple protocol to do. It's also a nice pre-exercise warm-up where you want to just get the tendon ready so you get a little blood flow into it. Now, the next few pictures get into what is like the gist of this lecture. Most tendinopathies aren't the result of the muscle stiffening because of advanced glycation end products. That's a small population of people, often, like I said, with diabetes. More often than not, it's athletes involved with explosive sports. It took me way too long to find good images of what happens internally to a tendon. There were very few electron microscopic studies. And this paper by Fung et al., they did a subrupture tendon to fatigue. And this is a watercolor painting of an electron microscopic picture. So if you look at the left, that's a normal tendon fiber. If you look at, as you go to the right, when you first apply a load to where there's too much force, say you're running uphill or jumping, you get little buckles that form in the tendon. Then you start to get where B is, you get little tiny tears. Then where C is, you get frank tears of individual tendon fibers that allow the tendon to get longer. Just think of it all interconnected, then a few portions rupture, and the tendon itself gets longer. So most Achilles tendinopathies, especially of the energy storing tendons, they're a problem with increased compliance, increased flexibility. So this picture took me forever to draw, and I love it just because it gets a complicated problem. It explains it pretty straightforward. So if you look at this little arrow here, right, that is the Achilles tendon lengthening because of partial microscopic tears. That in turn has to be taken up. The lateral medial gastroc have to take the slack up and the soleus by shortening. So several studies are showing that as people get older, they have preferential for reductions in force output, not in their hips or their knees. They have decreased force output in their calves, which people couldn't understand. And then a series of papers show that when the tendon is more compliant, the muscles pull up. And then if you look at the sarcomere with the actin and myosin filaments, they're forced to work in a shortened position. So normally, ideally, you're going to have maximum overlap so you can generate most force. Most people are familiar with muscle length relationships. So when a muscle's in a midline, as in this picture right here, you're going to generate the most possible force. When a muscle lengthens, there's hardly any actin and myosin filaments contacting each other, so you can't generate any force and you'll test weak. That's independent of how strong the muscle is. You will just test weak because there's no actin and myosin filaments touching. Now look at how rapid this line drops on this side. That's when the muscle is shortened. The muscle gets packed on itself, hardly any actin and myosin filaments in contact, so it gets significantly weaker. That decreases force output. The problem with an overly compliant tendon is that it decreases force output, which impairs gait. And that was that study by Piquet that came out of in 2017. They looked at middle-aged distance runners to try to figure out why they slowed down. They did not slow down because of decreased output in their glutes or knees. They slowed down because of decreased output in the gastroc, which the authors didn't know. They thought there was something about that muscle that made it different. It turns out it wasn't that muscle. It was that tendon got longer, so the muscle had to function in a shortened position. Now, to fix tendinopathies, historically, we have been going back to the 70s, have done heavy load eccentric training protocols, still really popular. Alfredson came up with them in the late 90s. The problem with the heavy loads, and I started to dislike them 25 years ago because I wasn't seeing great outcomes with them, is that 60% of people treated with heavy load interventions continue to have pain and discomfort 5 years later. That's a terrible success rate. And again, I started seeing that years ago. And as a result, I've always kept up with the literature to see if they were coming up with anything new. Just in the last few years, they're showing there's different mechanisms for which cause, for the reasons that tendons can heal themselves and how exercise can help heal a tendon rather. And one of them has to do with fluid flow dynamics. Some researchers from Australia, again, this is a 2022 paper, showed that when you isometrically contract a muscle, you squeeze fluid out of the tendon. Remember, a tendon is about 70% water, so that's a significant outflow of water. That in turn, that movement causes tenocytes, which are the repair structures inside tendons, to stimulate remodeling. So it's that fluid flow dynamics and associated with isometrics. Now, this was a study they wanted to identify what parameters of the isometric contraction make the difference that improve the outflow of fluid. And this study, which the reference is right there, also relatively new, they used three-dimensional ultrasonography. They varied the resistance between 35 and 75% full effort, and they varied the load durations from 2 to 8 seconds. They also had people perform heavy load eccentrics for comparison. They showed that the heavy load long duration caused a 13% reduction in tendon volume. That is enough to stimulate repair, and it was far and away greater than any other treatment group. heavy load eccentrics did not alter fluid outflow. Now, this to me is even the most important stuff. This is the importance of interfascicular sliding, and it's why when we started this video, I put that image up that showed all the tendon fibers are all individual and they all move on their own. So they started saying as tendons glide over one another, that produces a mechanical stimulation that causes the tendinocytes to stimulate remodeling. Now, in order for that to work, you have to have all fibers of the medial, lateral gastroc and soleus firing. Otherwise, you'll just be using a very small subcomponent of the tendon itself. You won't be using all of the available muscle, all of the available tendon fibers. And again, they have to slide on each other to stimulate repair. And I did not put this in the Journal of Contemporary Chiropractic article because it was running on too long. Until recently, people had no idea how mechanical stress of a tendon sliding could cause a tenocyte to remodel. And I found these papers in 2021. These two researchers got the Nobel Prize in physiology for studying mechanosensitive piezo ion channels. If you look at that picture on the top there, the membrane to the side is attached to these channels, but if you push down on the membrane, it causes the channel to open up like this, like a flower opening, and then that allows for the flow of ions and proteins and different other stimuli that cause enzymes to accelerate remodeling through crosslinks, not building collagen 1 fibers, not changing the structure, the width of the tendon, but by increasing the strength, by increasing the crosslinks. Now, what's interesting about this is that there's a variant of the gene that makes that piezo channel called the piezo allele E765DEL. That gene also does other stuff in lymphatics, other things, but it affects red blood cells and prevents people from getting malaria, which is fascinating because there's a real positive side of having that specific subcomponent, that gene, which is present in 30% of people from areas where malaria is endemic, markedly accelerates tendon remodeling. It's like a steroid boost that causes more cross links between the fibers and makes the tendon stronger. So in the paper below, Bassini et al., they did an interesting study where they took carriers and non-carriers of that gene, and the people who had that gene, when they were forced to do drop jumps, could jump 13% higher. So that gene is not just for remodeling. If you're lucky enough to have that gene, and again, people of African descent and people in the Caribbean, anywhere in other countries where malaria is endemic, but it's got a huge implication because now they're trying to figure out how they can use pharmaceuticals to stimulate that, although I prefer doing it with exercise. So tendon tears that alter fascicular sliding. This is important because if you look at this picture on the left, that little hole that's in the center, when you get a tendon tear, that hole is no longer united. So you can't slide the filaments back and forth. Without the filaments sliding back and forth, you can't remodel. So a lot of great researchers have claimed, give up on that area where the hole is, and then just focus on the areas of the tendon where you can still move the tendon fibers and get tenocytes to remodel. In fact, Cook made the comment, treat the donut, not the hole. And then if you haven't seen the work of Keith Barr, he's got a bunch of YouTube lectures up. The guy's a genius. He writes extensively on tendons. Him and the Japanese researcher Kubo, to me, have done the most amazing stuff with tendon remodeling. They showed that during prolonged isometric contractions, and if you look at the picture here, the blue line here, if you apply a fast load to a tendon, it gets near its failure point relatively quickly. But if you apply a long, slow load, the healthy tendons start to slide out of the way, tendon fibers slide out of the way. And what happens is that exposes the tendinopathic tendons to a longitudinal stress that can stimulate remodeling. So what Keith Barr recommends, and I've done for a long time, heavy loads that are about 70% full effort, so you should be moderately fatigued at the end, and you should hold them between 30 and 45 seconds. Keith Barr often recommends doing 4 of those reps 2 times per day. And then this is some great research. Hansfield came up with this. Again, this is 2019, relatively new. They used ultrasonography to look at what made the different tendons fire. So they gave people all these different exercises. And while they were doing them, they looked at which specific exercise causes the tendons to fire. And they showed the bent knee heel raise produced the greatest interfascicular sliding. And again, remember, as those fascicles slide over each other, you release enzymes because you've modified the mechanoreceptors in there, which causes tenocytes to add more collagen crosslinks to strengthen and connect some of those damaged sections. So it's really important to stimulate not just a small section of the muscle, but the entire section so that all the tendon fibers are sliding. And this is important because a lot of people from injury and different things, they don't fire their lateral gastroc. Francois Hug is a researcher who demonstrated when they do deep fine needle EMGs, if you put it on a medial gastroc, lateral gastroc, and have people do heel raises, sometimes you have like a 2-to-1 ratio where medial gastroc fires twice as much as lateral gastroc. Some people have an 8-to-1 ratio. That means they're not firing their lateral gastroc, which is not uncommon. And that means that entire region of the lateral gastroc is not stimulating the attachment. Remember, that's the attachment point that attaches in the front of the calcaneus. That's where Achilles insertional problems are. And several studies, and I put it down below, have shown that weakness of the lateral gastrocnemius contributes to Achilles tendinopathy, and weakness of the soleus also contributes to Achilles tendinopathy. But that exercise is one of the best. If you had to just do one exercise, that would be it. Now, if you want to, remember I talked about that gene that people who are from areas where malaria is common, they create more crosslinks and they get stronger tendons. You can strengthen a tendon just by doing isometric contractions. And this is the Albert protocol. We made this strap on our site just because it wasn't available. We don't charge much for it. It's just you generate so much force when you're doing ankle isometrics, ankle plantar flexion isometrics. It's good to have handles on it. A lot of the standard straps you don't. And in this study, they just had people build up to a 3-second isometric contraction, hip flex 40 degrees, knee extended, ankle dorsiflex 5 degrees. And they basically did 5 sets of 4 repetition on each leg 4 times a week of a 6-second isometric hold. This protocol increased metabolic efficiency by 4%. So, and again, that's a big deal because that 4% increase in metabolic efficiency is similar to what you get with the new super shoes that are out there. And the authors of some of the studies that show the super shoes increase metabolic efficiency always point out that your connective tissue is the number one way. If you want to improve efficiency, don't put on a soft midsole. Make your tendons more flexible. Your tendons can store and return way more energy than a new carbon plate with a very soft midsole. So the main reason this works is that as you start to do these isometric contractions, you decrease that compliance, you tighten that tendon up. And in that group that I was just talking about, they had a 16% increase in Achilles tendon stiffness, which makes the gastroc soleus work in a neutral position again. And Kubo has done several studies showing that isometric contractions can cause tendons to tighten as much as 50%. And then this is just a quick pre-exercise warm-up where you just do hold, relax stretches. You put your ankle in a neutral position, then press, then relax. This is research by Anthony Kay. It just is a nice way to warm the muscle up. That minute oscillation stretching can also do. This is what I wanted to get into, the role of the central nervous system in chronicity. When you look at a tendon injury, you would think, oh, I'll do an MRI. There's tendinopathy. That's causing the tendon injury. 35% of asymptomatic people have moderate to marked tendinopathy on MR, so it's got nothing to do with it. And this is research by Ebony Rio, which is just phenomenal. Look her up, the references down there. They have shown that when you have a tendon injury, your central nervous system decreases motor drive to that. So your body says, I don't want that injury to be perpetuated, so I'm just going to shut it down. That weakness becomes long-term, and it doesn't respond to conventional exercises. And what Ebony showed by using transcranial magnetic stimulation, that between the motor cortex and the midbrain, you have inhibition. They even know it's gamma aminobutyric acid. It produces the inhibition. That in turn decreases drive, not just to the muscle on the tendinopathy side, but bilateral. So you're going to get bilateral weakness when you get that intracortical inhibition. And that's a big deal. And this is research by Coombs et al., also out of Australia. They said you got to start thinking of tendon injuries differently. A lot of people have tendon pathology without a problem. A lot of people have motor stuff without a problem. It's when you have, and pain without a problem. It's when you have all three. So pain can also cause inhibition, which causes that intracortical problem where you can't drive it. So they have shown too that once pain starts in a tendon, you're more pain sensitive over your whole body. When you have an Achilles tendinopathy, you're more likely to report pain in your shoulder when compressed because the central nervous system takes over. So what do you do? And these are the reasons the heavy load protocols haven't worked, because they do not address the central component of pain. So how do you address that central component of pain? And this is some really nice research that Orsada et al. In Rio again shows that this one study showed that runners with Achilles tendinopathy had 14% more greater intracortical inhibition. And they also on that side had 38 to 34% decreases in calf endurance, which is used. And that's coming from the endurance from the intracortical inhibition. So you've got to address that. That's key. And then in this, so what do we do to fix the intracortical inhibition? One of the things you can do is heavy load isometric contractions. So in this protocol, they compared heavy load isometrics with heavy load eccentric concentric, and they showed that when you did the isometric contractions, it stopped the intracortical inhibition, and they had 20% improvements in strength. Now that's significant because neither pain nor strength was affected by the heavy load conventional strength training program. So it just shows you that prolonged isometrics are key to suppressing cortical inhibition. They also act as pain blocks. This is again another paper by Rio. Again, she's done a lot of research on this, and she showed that doing 5 45-second isometric contractions at near full effort produce pain blocks that last for 45 minutes. Before you send an athlete out to perform, you have them do a series of isometric contractions. That blocks pain. In this study right here, they were able to get a 6.8 out of 10 reduction in pain scores compared to 2.6 reductions in pain following conventional isotonic exercises. And then just remember, repeat isometric contractions allow athletes to manage their pain before sports participation without medication, because medications have significant side effects. A lot of the nonsteroidals can interfere with tendon bone remodeling, in fact. And then too much pain can cause problems. And that original study by Alfredson et al., I'll never forget it, because when I read it, I thought, you guys are different in Europe, because they said, do the exercises no matter how much it hurts and only decrease the intensity if the pain becomes disabling. And that was their word, disabling. And I feel that if you push the pain to that level, you are going to cause descending inhibition. You're going to have an amplification of the sensory process, and you're going to have more intracortical inhibition, which will worsen the process, which is another reason those protocols don't work all that well. Keith Barr always says you want to keep the pain to 1 or a 2 on a scale of 1 to 10. Now, this is some really interesting information showing that you can block cortical inhibition by exercising to the beat of a metronome. The rate of force development also increases when you exercise to a beat of a metronome. This is as simple as putting a metronome on 60 and doing heel raises, matching that beat frequency. They've also shown that when you do isometric contractions, and the protocol in the end will have it, you do isometric contractions, I'll have people drive down with their toes while doing an isometric contraction on their Achilles tendon to the beat of a metronome to change the motor engram to get them to fire their long and short digital flexors. So metronomes are incredibly helpful when it comes to treating cortical inhibition. And I don't know why, but this is overlooked all the time. I don't care if you're treating extensor carpi radialis brevis tendinopathy or an Achilles. If a tendon is broken down, you look at its synergists and strengthen them. 9 times out of 10, when someone's got an Achilles injury or any tendon injury, the synergists that fire with that muscle are damaged and they need to be strengthened. A classic proof of this, and it took me a while to find it because it just came out in 2021, they looked at people with Achilles tendinopathies and then they MRI'd them. It had significant increases in volume, compensatory increases in volume of their flexor hallucis longus and flexor digitorum, mostly flexor hallucis longus, to compensate for the Achilles injury. Flexor hallucis longus can create a synergistic force to the Achilles and offload a damaged tendon. So whenever you have a damaged tendon, you want to strengthen its synergist. If you're dealing with extensor carpi radialis brevis, strengthen extensor digitorum longus and work it through a full range of motion. Peroneus longus is also an important synergist to the Achilles tendon, especially when you're driving off laterally. It attaches to the medial forefoot. If you look at this little picture right here, that attachment stabilizes the whole medial side. If it's not stable, the rear foot can suddenly evert, which twists the tendon, which can impair circulation and increase the likelihood of chronic tendinopathy. In office, I made these measuring devices. If I want to measure flexor hallucis longus, I put it under the big toe and pull out. You should be 10% body weight. If you want to measure peroneus longus, you go right here, put it under the first metatarsal head, and then pull out. You should also be 10% body weight with that. High-level athletes, I like them being 12 to 15% body weight. Takes a second to do these tests, and it motivates patients to do the exercises. And if they come back in 3 months, you remeasure, they're saying, you know, they haven't done them. So it's just very objective. Jen Zhu on the bottom, a physical therapist in Virginia, did a reliability study on this 2 years ago, and they got moderate to excellent reliability and validity for doing this, for measuring toe strength. And it's just a simple, easy thing to do. And then don't forget tib posterior. Remember that tendon rotates 45 degrees before it attaches. If you look at this picture over here, it has a long lever arm to the subtalar joint, so it can stop the foot from everting. It can help offload the Achilles tendon. One paper that came out in 2008, a long time ago, didn't get any press. They looked at people with Achilles tendinopathy and without, and did 3-dimensional analysis. The people that had tendinopathy failed to externally rotate the tibia during push-off, which the authors attributed to weakness of tibialis posterior. This is my favorite spot. I should have started here. How much weight do you recommend when you're giving isometric exercises? And John and I talked about this when we did this last time. A lot of people just go 80% full effort, go near full effort. But these researchers, and this just came out in 2024, these researchers have shown that everybody's different. If you take one person and apply an isometric force that's 80% 1 repetition max, it'll stretch those interfascicles so much so they'll go near their 11% elongation rate. And that greatly increases their risk of injury. They have shown that athletes who routinely go past 9% fascicle elongation are 3 times more likely to have a tendinopathy. And then if you apply so little of a load that it doesn't move more than 3%, that's not enough to stimulate tenocytes through the mechanotransducers to stimulate remodeling. So these authors showed that 6.2% elongation was the magic load, and that happened with anywhere from 47 to 90% full effort. So I wrote the authors when I read this because I thought that's great information. But how do you know who you should do 47 to 90%? And it turns out without the ultrasonography, you can't tell. But I wrote them and said, if someone is really lax, if they have a ligamentous laxity, they are going to be on that end where they need to do like 40 to 45% one full effort, because that light weight will be enough to separate fibers in someone who's lax. Conversely, if they're really rigid, tight people, they're going to need to go to 90% full effort to get into that sweet spot. So overly lax people need to use light weights. Really tight people need to use heavy weights. The thumb radius index, you hold your hand like this. If you can touch your thumb or get within a centimeter of it, you have ligamentous laxity. There's other markers, elbow hyperextension, knee hyperextension, shoulder external rotation. That thumb radius is the most sensitive. And if you are within 2 centimeters, go to lightweight. And simple to do. It takes a second to do that test. So your 2.3-fold elevated risk if you go past that 9% mark. And again, that 6.2, this right into here, that sweet spot is essential when prescribing a weight. Now, this is really important. The reason that I thought you should use the thumb radius index is because I've seen so many studies where you can predict who has osteoporosis based on their skin elasticity. If you take someone's skin and you pull like this and it snaps up and doesn't go back down, that correlates with being osteoporotic. The two references on the bottom, and this is old data. I mean, this is 2000, 2001, 2005. It's been repeatedly shown that the collagen makeup of your skin correlates with the collagen makeup in bone. And I feel that thumb radius correlates with elasticity in tendons. People with Ehlers-Danlos are markedly more likely to get tendinopathy. And again, you should use light weights when you're dealing with them. And now this is one of the last things. Boson Moeller is one of my favorite researchers. He shows that when you're doing regular exercise, everybody focuses on going into ankle dorsiflexion, plantar flexion when doing their Achilles exercises. They showed if you do inversion, eversion, you can increase intertendinous strain and fascicular elongation by as much as 15%. That 15% is the difference between getting someone better and not getting them better. So when you're doing your eccentric or isometric holds or your strengthening protocols, you have to go full eversion, you have to go to full inversion. And if you're doing, you're rehabbing a tendon with extensor carpi radialis brevis for tennis elbow, you have to have radial deviation, ulnar deviation, so that you access all fibers of that tendon. And now how I treat it, I made this ToePro because research by Kubo, research by Uranchuk, research by Goldman shows that when you exercise a tendon in a lengthened position, it gets stronger at a 4-fold rate. They also showed reference 3, Uranchuk, when you exercise muscles in their lengthened position, it allows for a greater transfer of strength gains to dynamic performance. That is huge. Goldman demonstrated when you strengthen toes in a lengthened position versus therabands where they're shortened or short foot exercises where they're shortened, you get 4 times the strength gains. That is incredibly important. So knowing that research, I made a device that tilts laterally to stretch your peroneals, tilts back to stretch gastroc and soleus, and then cocks your toes back 40 degrees to match the Goldman paper where they got 4 times the strength gains. So they did a study on the ToePro at Temple University. They got 36% increased strength in the toes in just 6 weeks. But this was an important paper. I wanted to bring it up. They did tendon strengthening exercises, some with slight dorsiflexion and some with slight plantar flexion. The tendon only got stronger when exercised in dorsiflexion. The tendon only got tighter and stronger when it was isometrically contracted while lengthened. There was no change while it was shortened. So in the past, I've given a lot of insertional protocols where people are up really high. I don't do that as much now because I'll try to target lateral gastroc and have them do it in a lengthened position because lengthening is the key. And again, Kubo and others have shown this for decades now. I'm surprised it still hasn't caught on. So this is the protocol I came up with. It's in the journal article. I made a video of it. It's online. It addresses all components of the tendinopathies that I was talking about. You exercise to the beat of a metronome. You work the muscles in a lengthened position. You go at different angles. That's what these middle pictures are to do tibialis posterior and peroneus longus. This picture down here on the bottom is peroneus longus. You're holding a weight in your hand. You're going to 70-80% full effort if you've got normal tendon resiliency. And you push laterally by everting your heel, driving your foot down. And all of these exercises are done or finished with the 30-second hold that is recommended by Keith Barr, where you drop down, hold it in a fully lengthened position, with the knee slightly bent, which duplicates the hand feel study that got the maximum loading of the fascicles, and then do a pulse action of your flexor hallucis longus while doing that. So you're getting a motor engram to your great toe. You're firing the Achilles tendon in a lengthened position. Just works incredibly well. Again, John will give you all of these slides so you can go through it. I had a friend who's an athlete go through the protocol. I don't know if we have time. I don't know if, John, you want to pipe into it. It's like 3 minutes to show these exercises.
Yeah, sure. If you want to run through them real quick.
Yeah. You okay with that?
Yeah.
So this is just the standard. I'll let Kim do the talking here. She's setting the metronome at 80 beats per minute. I chose 80 beats per minute because it matches the cadence of a runner, and most studies use 20, which I don't like. I want to duplicate the motion that a runner does. So if you look at her, she just did the 4 times 25 protocol. She does a set of 25, so at light resistance, so she's fatigued at the end. A researcher named Bird showed that stimulated hypertrophy as much as heavy load exercises. So I have people do a set of 25 to fatigue. And now look at her foot there. She's doing an isometric contraction on her gastroc and soleus. Metronome is set at 80, and she's going pop, pop, pop. She's tapping to that. So you'll do that on the other side. And then once you're done with that, you just do a 30-second stretch. Now to do tibialis posterior, it's the same thing, except you're sidewards. And she'll just place her foot, and you'll see it right here. She places her foot right on top of it, leans sideways to the wall, and she would have a weight in her left hand, but because she was talking, she couldn't do it. And then you'll do a set of 25, raising and lowering. And so your foot is maximally everted now. So you're getting the medial side of the Achilles tendon. The knee is slightly bent. And when she finishes that, she'll do an isometric hold here with the foot fully everted. This loads tib posterior like you wouldn't believe. And she pulses to that 80 beat. You see her soleus popping out, her tib posterior pops out. And then you finish that with a toe-in stretch to stretch tibialis posterior. The next one is my favorite one, and that is proneus longus. This is just the best thing to do for athletes in general. They showed that cutting athletes, if you took the best athletes and had them do an agility drill, the fastest ones have the strongest toes. And that's been consistently shown because the last thing you're doing when you're changing directions, you're losing proneus longus, flexor hallucis longus. So if you have a soccer player, the average soccer player changes direction 700 times in a game. She's tilted slightly to the ball. Great toe is up on the board, so her flexor hallucis longus is lengthened. She does a set of 25. And now she's doing a 30-second isometric contraction right there. And again, the PDF has pictures of all these things. And then she just does this part. She pulses her medial forefoot into the foam, and you will feel a burn in your lateral compartment like you've never felt in your life. I do it on everybody with ankle sprains. Works unbelievably well. Follow with a 30-second stretch, and just crazy easy to do. Now, I talked about this with Achilles tendon, but it applies to all tendons. You know, the protocol where you do isometric contractions in a lengthened position. For greater trochanteric pain syndrome, I'll just have someone get on their side and have with the leg either in front or back, do different isometric contractions to the beat of a metronome. And same thing with if I'm treating a tennis elbow, I'll just have them hold a weight, go back and forth, also done to the beat of a metronome. And really easy to do, safe, low injury rates. The strengthening component is lightweight, which I like because a ton of new information. A meta-analysis just came out a couple of days ago, showed that the lightweight protocols create an anoxic environment where blood can't get in, and that causes a shift towards fast twitch fibers. And it produces greater strength gains than the heavy load protocols. And again, you don't want pain when you're dealing with Achilles injuries. So the bottom line with all this is that metronome-based exercises with prolonged isometrics are one of the best things you can possibly do to treat these. And then going through a full range of motion, keeping the tendons in their lengthened position, and then later stages of rehab, plyometrics, sport-specific drills. A lot of this stuff is just to get you out of the pain cycle and get you going. Then you can use all the trainers out there. You're the ones that are getting people better. Come up with different protocols that'll be sport-specific. And you're going to see way better outcomes. I've been doing these protocols for the last 5 years, outcomes have gone through the roof, especially with athletes. I just love them. And that's about it. I think I did that in 30 minutes, but maybe I did.
Did you have the timer going in the top
No, I
corner?
didn't. My clock isn't working. It's just one of those things. Hey, look, I got like a sand dial here. That wasn't working. That's for my isometric contractions.
Waiting for Brett Winchester to jump on and time you out there. That's so much tremendous info, Tom. And before we get into some of the great questions that are listed here, can you go back to the turkey slide?
Oh, sure.
Would you mind? And
not at all.
Yeah, you're so humble. When you look at all the pictures on there in this paper and on, I'm sure some of your books as well. So your wife drew that turkey picture,
yeah,
correct?
I thought you were going to say what a great artist I was. My wife did this. It was the only one I didn't do.
But then all the other pictures. So flip to one of the other pictures that you did. I mean, it's like to be able to visualize that and then at the same time to be able to draw it.
Yeah, this is the one. In fact, I did all these components, but I drew a terrible picture of this that my wife put together because she does a lot of design and she takes my stuff and cleans it up. But I do the anatomical pictures, and she also did this picture, which I just like doing anatomical pictures because that's my strength. But yeah, anything else, I farm out.
So impressive.
I just said, Tom, that's just not fair.
Right?
Unreal. I mean, I thought I had a little creative edge and it just blew me right out of the water, but I'm excited. Thank you for that presentation. There's so much to pick up. I got to read this thing over again for sure. And then I've got to put some of these principles into play because what's wild about it, Tom, is that I think it really meshes just organically with what I've learned spending all my time the last 40 years being on site working on athletes as they compete. I've got zero time to go through, well, maybe this technique will work or this technique will work. That doesn't play when you're on site. You've got to have something solid that you can go to that'll work. And many of these principles, though you state them much more eloquently than I ever could, are exactly what we use with SPRT, not only in the soft tissue, but in the taping principles. So I'm excited to explore this more and see where more synergies are.
You should take a look at this paper here, the Nobel Prize winners on piezo ion channels. Some of the most complicated stuff. I've been reading it for the last week, and I want to shoot myself sometimes. You go over it, and like it is so complicated to try to distill it down. Like I did this illustration to show shear stress, but in the Nobel Prize winners, they had a paper. They just had, they could have had a thumb going down on the membrane. This is the first research, and it's all new, that shows mechanical pressure alters the chemical component of muscles, tendons, and ligaments and makes them stronger. And what was interesting is that they've always argued the tendons get bigger, the tendons get smaller, do you lay down more collagen? These guys are showing you don't lay down more type 1 collagen. You have a certain amount when you're born, and you have that amount the rest of your life. What this does is it lays down crosslinks, enzymatic crosslinks, and that's what makes a tendon better, and it's accomplished through touch. I only went in with this with the membrane potential for shear stress because I was talking about interfascicular elongation. They're doing it for hearing, for pressure, for sensation, and it's mechanical pressure. I was going to redraw where it's just a finger pressing the membrane, and it just causes that ion channel to open up. Cations flood in, and for reasons that no one still understands, that changes the enzymatic cross-linking system. And again, if you're lucky enough to have that piezo 1 allele, like not only won't you get malaria, but you have the strongest tendons, and they store and return energy like you wouldn't believe. In one of these papers, they just looked at people who had it versus people who didn't. They looked at people who jumped, and then they looked at people who did drop jumps. And the people with drop jumps just took off if they had that gene.
Wow.
Yeah, so it works okay for just jumping, but like if you're jumping in the air, you hit the ground, you take off, it turns your tendons into springs. I just loved it. And they have been trying to figure this out forever. I mean, even when I was writing this article a little while ago, people go, no one knows the mechanism why exercise stimulates repair. This is why exercise stimulates repair, because of piezo ion channels. And I have almost everything ever written on them. So if anybody wants the papers, most of them, luckily, were open access because they're Nobel Prize winners. So I've got a ton of references. Just contact me through email. And anybody out there wants to reach me either through the site, or my email address is my name, tommichaud@aol.com. That's right, AOL.
Well, that's cool. Thanks, Tom. Hey, I wanted to just drop in real quick before we get going with the other stuff, that how similar the body works in different areas, because just reading some of the Stecco's work on fascia and the discovery of shear forces across fascia, stimulating a cell production of a new cell now called fasciocytes that produce hyaluronic acid. So all these things working simultaneously together and in concert and rhythm and synchrony are incredible. And I don't say rhythm and synchrony lightly, because now you added the metronome to all this. So the body works with rhythm and synchrony. That's no lie, literally.
Yeah, I wrote a paper on Parkinson's a little while ago because I saw some research showing that when people were first diagnosed with Parkinson's, if you had them exercise to the variable beat of a metronome that they had to match, they didn't know what beat was coming up, it delayed worsening of the Parkinson's. And they showed that basal ganglia has a section, the substantia nigra goes to basal ganglia, goes to create a movement pattern. It bypasses, it creates alternate movement patterns. And while doing research on that paper, I found a couple of studies that showed that people who do Irish dancing and tango dancing have slower progression of Parkinson's because of the variable beat frequency. So, when you think about the cortex locking in, I mean, I think our profession, myself included, is focused way too much on just the mechanical component of the tendon or the fascia. You have to look at what's driving that. Like, I love Carlos Stecco's work, but spindle activity is being driven by the central nervous system, and that regulates tension. I mean, the spindles are the tone receptors. So, I made those focal muscle vibrating devices based on research out of Europe that showed if you oscillate a muscle at 60 cycles per second with 0.5 millimeters displacement, you produce presynaptic inhibition of the muscle spindle and you change tone. I play tennis all the time. Before I play, I put a small little motor, they're around this big, put it on my infraspinatus because I've torn a couple of tendons in the past, and my shoulder, I don't even feel it. And research out of Iran showed that if you put it on infraspinatus for just a few minutes, you got an 11-degree increase in range of motion without the negative side effect of stretching to get that range of motion, which can impair performance temporarily. So it's just an easy way to suppress spindles. And if you look up the article I wrote on focal muscle vibration, you vibrate a muscle while isometrically contracting it, it drives the vibration deeper, goes through the fascia, shuts all the spindles down. And the outcomes increased, force output increased, jump height. A chiropractor I know down in North Carolina has been treating a high-level heptathlete who had a hamstring injury. It got better with just a few sessions. I had a distance runner do it on Peroneus longus. They've shown if you do focal muscle vibration on tight muscles, you palpate Peroneus longus as being tight. You put focal muscle vibration on that, they have immediate improvements in balance. And then, we're talking about this gene here. I came across a paper the other day. I told you I got too much free time. I came across a paper the other day that showed the chromosome 11 has a gene on it that determines muscle stiffness. So if you happen to have that gene, you're going to have stiff muscles through your entire body. And is it a problem because of the way collagen is laid down? Is it a problem because of how spindles are affected? There are genetic variations, just like you have Ehlers-Danlos syndrome, you have like tight person syndrome. Wow. So it's just fascinating stuff. And Carlos Stecco's work, I love. I mean, I remember when I first read that book, I couldn't put it down. How boring! Yeah,
fascinating stuff.
Yeah.
Thanks for sharing.
Hey, Tom, real quick, before we get into some of the great questions, you were just talking about focal muscle vibration. Was there any research around the specific hertz that was most effective?
Yeah, and it depends on who you read. Like if lately they've been coming out with saying 30 to 40 is the best, But all the, in my opinion, best research where they did like H reflex, M reflex, and did everything, 60 hertz with 0.5 millimeters displacement. 40 to 60 seems to be a magic number. And they always said 0.5 millimeters. It took me a year to make that stupid ass thing to go to just 0.5 millimeters. And then the papers come out showing that 1 millimeter was fine. But then some studies show if you went to 1.5 or 2, which is what a lot of vibrating machines do, you don't suppress spindles. If you want to see if it suppresses a spindle, you put it on someone's soleus muscle on each side, have them cross their arms and close their eyes. If they have a history of back pain, when you close your eyes and you're standing, you're relying on spindle information from your soleus to keep you going like this, and you're relying spindle information in your rectus spinae to keep you from going like this. When you shut them off by putting the motors on soleus, and it feels like this light buzz, it goes bzzz, you barely notice it. But if someone has impaired core proprioception, they're overly reliant on their ankles. You shut it off with those motors, in seconds, they start to fall over backwards. They'll move 4 to 10 centimeters. And research out of Europe showed they are 4 times more likely to injure their back in the next 2 years, independent of MRIs, independent of anything, because it's a measure of core proprioception. Crazy easy to do. Almost every patient I ever had, I would put those on and see if they swayed. Professional dancers are the best. They barely move at all. If you have good core proprioception, you don't even know whether you put those motors on. But if you put those tiny little motors on someone's calves and they look like they're falling off a diving board, they have no core proprioceptors. The proprioceptors, the spindles, are located in the slow twitch muscle fibers, which require tons of blood flow in order to function properly. And when you're injured, you are deconditioned, you don't have the circulation to supply the spindles, and then the spindles stop giving information. If they do not give information, you're not going to know where you are in space, and you're going to get hurt. And in fact, they have shown that the diaphragm takes blood away from the low back and hips once it's fatigued. So the authors of one paper said in the last few minutes of a basketball game, if someone's got a fatigued diaphragm, they're going to draw blood, which they've measured with infrared spectroscopy. They're going to draw blood away from the muscles, put it in the diaphragm. Now the spindles don't know where they are. And when you're jumping, you don't know where your body is. It doesn't matter what your fascia is doing. If you don't know where your body's doing, you're going to tear something. So they have, like I experimented, I worked with a couple of different research facilities to see if you could restore that proprioception. I thought mobilization would fix it. I thought deep tissue work would fix it. Endurance training fixed it. And diaphragm training fixed it. So that was neat stuff. And that's a separate paper, focal muscle vibration. I have 2 of the papers. One was on the new research showing that when you do with a prolonged isometric contraction, you reset the spindle. You're familiar with the fascia, the perimysium. The spindles are housed in the perimysium. So if you have stiffness in one area, the spindle's not going to tell you where you are in space. So I start to look at all soft tissue now, how it allows you to communicate with the central nervous system. The central nervous system is driving all this. And it's this spider web. And you can work one little area, but you have to wake it up. Then you have to decrease the intracortical inhibition. So isometrics, manual work, and then sometimes tricking it with focal muscle vibration, which is easy enough to do. Strength training with a muscle in a lengthened position with an isometric contraction. One study, they did 3 10-minute contractions on their quad with the focal muscle vibration. They had like 60 to 70% increases in jump height. They were older people who didn't jump that high to begin with. But changes in athletic performance are just huge. I've treated a ton of pro athletes in the last 40 years. And a lot of them are getting in touch with me now saying, how do I set this up? And it's easy. It's also cheap. I think we charge $75 for the stupid things. I mean, half the stuff on the site we charge next to nothing for. I just want people to have it.
That's awesome.
Well, real quick, while you're on the topic, would you give us the information for your site, plug your site real quick, just in case anyone wants to go?
Easy.
Everyone
the book
should.
I wrote is called, thanks for asking. The book I wrote is called Human Locomotion. So the website is humanlocomotion.com. It can be tough to navigate. Like if you want to get information from it and not buy anything, just go to my article section. I have over 50 articles on any subject. My favorite ones are the focal muscle vibration, the new one on this tendon injury, I'm going to do one on plantar fascial injury soon. And an old one on plantar fascial injuries, but just tons of it. The Parkinson's I made a metronome app that matched one of the research papers where they did 20 seconds on at a fixed cadence and 40 seconds at a variable one. I made a 20-minute version of it. So if you have any patients with early Parkinson's, it's a free download. You just click on it, load it to your phone, and then get on a stationary bike. It's a lot of fun. You can feel your brain getting confused as you're trying to match the metronome frequency. And then the articles on focal muscle vibration, you just can't beat those little things, and the medial drift device. But again, 90% of what we sell is that toe pro strengthening. I made that thing to prevent falls in the elderly. And right now, every NBA team uses it. Half the NFL uses it. Every distance runner uses it. And, that was just by word of mouth because I really made it for fall prevention, although it's slowly starting to catch on with fall prevention. That was I wrote an article, a 30, 40-page article with 105 references on fall prevention. It's a series of 12 tests you can do in office. You can do at home. It assess your risk. It assess your strengths and weaknesses. Do you have impaired proprioception from decreased cutaneous receptors? Do you have weak quads? Do you have weak calves? Do you have poor balance with a tandem test? And it gives a series, do you have bad agility? A series of home tests you can do, give them a score, and then you base the treatment intervention on what their weaknesses were.
So great. And a great transition. You were just talking about diaphragm fatigue. And our good friend, Dr. Skip George from Posture Restoration Institute had a great question. But Skip, anything that you wanted to chime in with regards to that topic or that conversation, or
Well, I love what Tom you were saying. I mean, we could just talk about this topic forever with the diaphragm being a muscle respiration and a spinal stabilizer. Then when it gets fatigued after exercise, shunting blood away from muscles. I mean, that's such a great topic I'd like to explore. So that just opened the door for me. But one of the questions I had was if you could discuss tendinopathy, Achilles tendinopathy, regarding pes planus or flat feet and high or normal arches. If you have some succinct thoughts on that during this discussion.
Yeah, that's pretty straightforward. That goes back a ways. Some people will argue there is no connection, but there have been several high quality studies that show that when you pronate rapidly, you increase the internal rotation of the Achilles tendon, which impairs circulation to regions that already have impaired circulation. So you load the medial side more. So you're more likely to get an Achilles tendinopathy if you're an overpronator. And then I've noticed the cavovarious people tend to get insertional tendinitises, which just because their foot is so rigid and tight, the lateral gastrocnemius attaches to the front, and that can increase the lack of tendon sliding where lateral gastroc is. But like I said, with my insertional Achilles now, I put that muscle oxygenation sensor up, Moxie they're called, reasonably priced. You put one on the medial gastroc, one on the lateral gastroc, and have them do heel raises, and then do them in different positions. You'll see where they desaturate. It just measures oxygen content in muscles. Nick Studholm, a chiropractor in Colorado, turned me on to him. He knows tons about him, way more than I do. And I just use them as EMGs. So if you see lateral gastroc not firing, then you have them go toe in and see if that desaturates. You want to preferentially desaturate that muscle. Now, I personally like using my hands. I've had the most low-tech practice my entire life, and I started playing around where I took those sensors off and I started palpating. And if I had one finger on medial gastroc, one finger on lateral gastroc, I know I could tell just as well as that Moxie sensor could. And I used to do that 25 years ago when they showed if you were trying to fix a laterally deviated patella, you wanted to get vastus medialis obliquus to fire. So they put needle EMGs in there. I just used to palpate, and I would tell people while I was palpating, I'd say, fire this muscle, and my finger would be on VMO. And then I would say, don't fire this muscle. And then I'd have them increase their intensity and practice it, and then I'd show them how to do it at home. And they do isometrics. They would change neural drive. It's called muscle signatures. I've been meaning to write a paper on it. Whenever you choose a neural pathway, you're choosing the same fibers all the time. And injury, different things will make you choose some pathways over another, and you'll preferentially recruit wrong muscles. Like you'll not fire your flexor hallucis longus. People with Achilles tendinopathy, pronation is important. I used to think it was the end all, A varus, we have those two-piece varus posts. They decelerate the velocity of the snap that stops the tendon from twisting suddenly. But take someone's insole out and look at the insole. If they have a ton of wear under the metatarsal heads, but nothing under the great toe, then they're not firing their flexor hallucis longus. Great athletes, you see giant holes. Often they'll wear, really good athletes will wear through the insole beneath the great toe. So what you want to do is take that insole, put it, and then I use that toe strength dynamometer. I mean, I love that thing. I think we charge $75 for it. I just made a new attachment is for identifying plantar plate injuries. It's just the size of your pinky. It's just an attachment that goes under one toe and then you pull. And if someone has a plantar plate injury, they have intracortical inhibition, they can't even fire that. I had an NFL guy with a $30 million a year contract, had a plantar plate injury, got the worst treatment in the world for it, and the nicest guy. And then another runner that I saw a little while ago had a plantar plate injury. They're just looking for advice. They don't even get good information. And in fact, because of those two, I have always disliked metatarsal pads. They support beneath the metatarsal heads. They're great for plantar plate injuries, but they're too high, they're too round, they're not shaped properly. So I've spent the last 3 months, I custom molded a small little metatarsal pad. I can't believe I have it here. So I made this mold in a pressure chamber, carved this little baby out. I took a study that had 170 x-rays in it, and I measured the parabolic curve of all the metatarsal heads. And then I took every lateral x-ray I could find, and I measured the angle of the distal portion of the met pad. And then I molded out of epoxy. Then I sent it out for 3D printing, and it's coming back from the manufacturer in about a week or so. And I love these. It has an arrow that tells you where to align it, how to hang it off. I've had really good feedback from the people who I've used it for, people with plantar plate injuries, people with metatarsalgia, people with rheumatoid arthritis. And again, 40 plus years of using metatarsal pads, I hated them. I mean, my brother owned an orthotic laboratory, and I used to yell at him, like, don't put the met pads. They put them too far back or they're too high. And laboratories use those thick rubber ones because they get them for 2 cents, and they don't work that well. You know, I was always using the Hapid ones because a study came out years ago in Foot Ankle International showing the compressed felt worked well. But the compressed felt, I have one of them around here, it looks nothing like a foot at all. You can tell I've been working on this thing for a while. This is a Hapid metatarsal pad. I think this is a small. That's more like a hard support, right? Your metatarsal heads aren't in that alignment at all. I actually took the 170 x-rays and made a graph of where, you probably can't see it, where all the metatarsal heads on average are, and I duplicated that parabolic curve. And then I measured it in the sagittal plane. So yeah, it's a metatarsal pad that's actually going to work. And I made it out of an EVA with a short diameter 40. So it's going to be, it's comfortable. My stepdaughter is a distance runner. She was a sub 3 hour marathon runner. And she came over a couple of weeks ago, and I only had one prototype left, and she had a bone bruise on her metatarsal head. So besides having her stretch her calf, I just put that in. And she called me up the next day and said, I can't believe it. Like that, the pain is 60, 70% gone. And it's just comfortable and easy. But that's just one more product, and we're always coming out with new stuff.
Well, it's a good thing that you're retired, so you have more time to work.
Ain't that the truth?
Thanks so much, Skip. Really appreciate it. And we had another question from Dr. Mike Rentala, who works with DNS. He's a dynamic neuromuscular stabilization expert. And Mike, I don't know if you want to jump on real quick, if you want to turn your mic on or if you want to turn your camera on. If not, Mike had a question regarding with the study showing the oscillating stretches with a TheraBand, do you think we can get the same effects using a slant board or other more stable surfaces?
The minute oscillating stretching was unique because they went through a small range of motion. It was just like 5 degrees dorsiflexion, 5 degrees plantar flexion with a cadence of 60. So it was moving like this. Because it's so mobile and the resistance was so light, they're diabetics that are deconditioned. I would just use the TheraBand. I made that strap. I don't have one here. It just has handles. But I wouldn't even use that because you have to move your hands with it. I like the TheraBand because the TheraBand will allow you to just push in cheap, easy. Technically anything you did, but it would have to be light. You couldn't do, if you were doing a slant board with body weight, TheraBand's probably 15% body weight. I think it just suppresses spindle activity. So it's not high enough force to stimulate tendon remodeling in any way. It just calms the spindles down by increasing circulation. I mean, you could potentially do the same thing by putting focal muscle vibrations on them. I mean, they've shown that. You put focal muscle vibration on the gastroc and then have them just do some balance exercises, and that increases their ability to stand on a forced platform.
That's great. And Professor Dr. Pat Helma from Western States, which is your alma mater, correct, Tom?
Yeah, I was saying he wasn't born when I got out of there, but I don't know.
Pat had a question about the piezo ion channel. Pat, did you want to ask that question, or do you want me to read what you wrote?
No, it's kind of similar to the way we look at concussions, right? It's a mechanical force causing a chemical reaction in the brain, similar to the piezo ion channels. That just kind of blew my mind, and I'm like, oh crap! Now I got a bunch more stuff to read and try and figure out.
This stuff is brutal. I don't want to scare you. This stuff, it took me 3 hours today to write this little summary because I couldn't make sense of 90% of the stuff they were writing because they're all Nobel Prize winners. They're just writing to each other. It's like, oh, I was doing this and I was doing that. Like, whoa, no wonder nobody knows about this stuff.
No, I appreciate it though. That's amazing. Thanks.
Yeah, it was really cool. And I wanted to put a picture, like I said, of a hand moving that membrane because pressure, it's not just exercise pressure, it's manual pressure. And Jeff Bove is a chiropractor researcher. He was at the Osteopathic College up in Maine. He just retired. He did some amazing research showing what manual therapy can do for nerve function, for pain, for connective tissue. And I have one of his articles. I made a summary of it. It's up on the site as well. And again, if you want any of these, I've got files. I think I have 7,000 articles on my D drive now. So if you want articles and you don't want to go looking for them, just contact me directly. I'll save you some time.
Well, that's perfect. And actually, Tim's going to get into a little bit on soft tissue and manual therapy here in a second. So that's a perfect segue. But we had one more question from Dr. Nelson Santos, who used to work with us on the AVP Pro Beach Volleyball Tour, who's currently in Paradise in Brazil. Nelson, I'm not sure if you want to jump on real quick, but Nelson had thoughts on tendinopathy in athletes running on artificial versus natural surfaces. Any thoughts on that?
Well, it's low. There are differences in impact forces, artificial versus natural. The main difference is that on a natural surface, you're going to get more inversion, eversion. And remember Boson Moeller saying you get 15% more tendon sliding. You're going to get more fascicle elongation on a natural surface. So you might want to start doing some rehab on a surface that you're not getting huge variations in terrain. But you're always better off with something where there's large variation in terrain. In fact, I made this 2-to-1 ankle rock board. Your subtalar joint inverts 18 degrees and everts 9. So all rock boards go 16 degrees. I made this small rock board that's out of rubber that pivots through the 18 degree, 9 degree range. I have people put their forefoot on it, have them lean into a wall, and then I just have them, as they're leaning forward, so they're plantar flexing into it, have them invert and evert. And that is a great load on the medial and lateral sides of the Achilles. You feel your tib posterior fire. You feel your peroneus brevis fire. Again, it gets down to the thing. Fascicles, there's hundreds of thousands of fascicles in a tendon. They all have to move. And if you limit the movement, you're going to cause a tendinopathy. Tendinopathies happen because of decreased stress, not because of the first tears happen because of increased stress, but then those sections aren't loaded. And that's where tendinopathy comes from.
Thanks so much, Tom. That's great. Tim, do you want to just briefly, real quick before we go into any more questions, just chat real briefly about SPRT and kind of some of the principles that lead into this? I mean, typically it's about, the importance of improving soft tissue quality in combination with then using the functional taping to support and guide and repattern movement. And then the importance of then moving into reconnecting the neuromyofascial system from there. And so typically we'll talk a little bit about, different protocols and techniques for improving soft tissue quality, working with the nervous system as opposed to against it. And then a little bit of tape, and then we'll move into the importance of moving and exercise after that. And we did that in a little bit reverse order today with Tom's amazing info on tendinopathy and exercise. But would you want to maybe jump off the mute and just give us a little information on your background and then a little background on SPRT?
All right. Well, I'll just go through this one real quickly, just to kind of show you. I think there's more similarities in what we're talking about, Tom, with regards to what you're speaking about and what we've been doing. Interesting to see what your thoughts are as we go through this, but I'll just go through my slides really quickly. This is just my background. Obviously don't want to lean into this too much tonight, but this just kind of shows where I've come from. My years of working as a sports chiropractor. I've been out about 40 years, and I was a high-level beach volleyball player and qualified for some of the pro tour sites with the Association of Volleyball Professionals. And then they, right at that time, went professional. And so they asked me to become their medical director because I knew most of the players and we shared similar injuries and certainly talked the same language. So I was able to bring out an interdisciplinary team into the Association of Volleyball Professionals. And it's kind of the same philosophy that exists today, where kind of alone, we're but a drop in the ocean, but together we make up the ocean. So I bring in everybody that I can find that can add something to the table other than a fork when it comes to an interdisciplinary team, because it's something I always wished I had as an athlete, never got. But I'm just going to kind of give you a little brief overview of what SPRT is, and perhaps you can see some of these similarities, because we're really about sliding tissues. We're really about finding a way to let the layers of tissue slide. And those areas that need to slide are the areas that we find are most tight when we move. So SPRT soft tissue release is a light, pain-free neuromyofascial, because we're hitting all the layers and all the structures in those layers. Myofascial release technique that uses progressive movement challenges. And we start with passive movement, we end with active movement, and then we finalize it with closed chain movement when we do these soft tissue passes, while applying multiple horizontally oriented unidirectional strokes to skin over areas of overused understretched muscle and soft tissue tension found in acute through chronic musculoskeletal injuries. Our whole objective is to improve the slide and glide between soft tissue layers to decrease mechanical and sensory motor stress on injured soft tissues. Typical SPRT sessions should reduce 50 to 80% minimally. And we test before we do the work, we test during the work, and we test after the work. That's a huge component of our philosophy and approach. But we expect huge outcomes with these things, because we believe we found a way to find most of these muscles that are, like I say, creating the imbalance on the musculoskeletal system that actually cause these injuries. And to Tom's point, why certain injuries don't clean up while we work on them. We have everything cleaned up in their physical person, but do we have them reconnected to their subsystems? So remember, when we injure an ankle, we injure the ankle that's in the brain as well. And so we disconnect those subsystems upon injury. It's like having a miniature stroke when we have injuries. So we must reconnect those subsystems before we're able to completely cure what we have going on and be ready to go out there and compete again. This is a piece I wanted to show you kind of how we're way into the skin. We treat the skin. There's a law in physiology called Hilton's law, and it states that every structure below that's in a soft tissue below the skin grows nerve endings back into the fat through the fascia and into the skin. So we utilize those cutaneous nerve receptors in a way that we can stimulate with our soft tissue strokes. We find the layers of these particular tissues that are stuck together and apply our strokes while using movement. And it's just kind of an incredible response that we get, especially when you take into account working on athletes right before they compete. Working deep on them is contraindicated. So we had to come up with a system that worked, that didn't have that deep effect where we disconnect subsystems, but still gave them the effects of being able to get tissue work, being able to improve their physiology and their approach before they go out and compete. And then we deal big time in proprioception. That's really what we're trying to do when we stimulate through the skin, is to improve proprioception. And then this is just a little schematic to let you know where our proprioceptors lie: 70% in the musculoskeletal system, 20% in the inner ear. That's why we do balance drills when we're rehabilitating, and then 10% in the eyes. So if we're lacking the ears and the musculoskeletal system, the eyes are our last objective. And one of the analogies I use is that after you've been on crutches for a few weeks, or after you've seen somebody on a crutch for a few weeks and they let go of that crutch, the first thing that they do, if they've had a sprained ankle, the first thing they do is they watch their foot while they walk, because they've lost that proprioceptive connection from the musculoskeletal system. And what they're utilizing now is the eyes until the musculoskeletal system comes back online. We use Yanda's principles. Every athlete you see, before you even touch them, has, or before they are even injured, had imbalances that were predictable. So we utilize these imbalances when we look at our athletes, and we watch them move, and we're always trying to correct the imbalances through the periphery first. If someone's got a rotator cuff injury, we'll want to clear the periphery out first before we even get into working on the shoulder. And then we want to restore muscle balance, which is a lifetime challenge for all of us and every athlete. We also have a right side that's completely different than our left side and will never be the same, but we move towards muscle balance. That is the goal. And then, of course, while we're doing this, we're utilizing taping systems and our hands-on systems to improve afferent and efferent input, so that we can facilitate reflexive stabilization. And then, of course, we want to increase movements over time so that we can improve endurance and coordinated movement patterns, i.e. the motor engrams that Tom was speaking about. So a lot of similarities in what we're doing here. We take it a step further here, and we really focus in on mobility of the ankle joint, especially in dorsiflexion, complete hip mobility, and then thoracic spine and rib cage mobility. And of course, this is coming from Gray Cook and Dr. McGill up in Canada. So they created this system. So we utilize other systems to help provide a reason behind why we do the work in SBRT. And then finally, you can't leave out the body, working on the body, without focusing on the foot. So to Tom's point, the foot can either be a great foundation, or unfortunately, oftentimes it becomes a weakness in our foundation that we must always focus on. So I'll get back to the conversation now, but I just wanted to give you kind of a brief overview of what we're doing in SPRT, both in the soft tissue as well as in taping. And John, you can certainly add in anything that I might have missed.
Oh, that was really great. Thanks so much, Tim.
Yeah.
And Tom, you're back?
There I am. Voice working?
It is. And thank you so much to everyone who's stayed on here. We're going on almost 2 hours, and we know it's late for a lot of you. So appreciate it. And we just want to get any closing thoughts from you, Tom, before we go. And then we'll add to that before we go.
Yeah, I mean, that's such a complex question. What would you do to treat someone to prevent injuries? They have shown, or
even from a performance perspective, any of us looking back, right? When we look at some of the things that we could have done to be, either higher level athletes or reduce the risk of injury,
Well,
Obviously,
it's the same stuff, kind of. You want to make sure, like I look back at the way I treated people in the 80s, like high level athletes, gold medalists. I wasn't given isometric contractions with heavy loads, and like some of those athletes, I know I would have gotten better a lot quicker. So, like when someone comes in, I think best thing you could do is to have a good knowledge of the different types of exercises, how you respond to them when they're prescribed. So you need a good chiropractor, physical therapist, good trainer, because things come up. So no matter how well prepared you are, these things are going to go south sooner or later. That's just the way it is. And if you have someone who's really knowledgeable in your corner, but just improve tendon resiliency, make tendons tighter, balance muscle tendon strength. And then I always did scans. I mean, to sideline hip abduction. I want to find tests, and I'm obsessed with it, finding tests that predict future injury. In fact, one paper showed that if you did strengthening muscles of the intrinsic muscles of the arch, you had a 240% decrease rate of foot ankle injury. So I measure intrinsic strength with a dynamometer. And if I find it, I use strength preventively. I measure diaphragm strength. I measure Moxie blood flow. I measure functional tests that I love, like sideline hip abduction. Do they go out of plane? Multifidus lift test, Fleming's test. So I try to do every possible test that has, I like evidence-based medicine that correlates with future injury and then do things to prevent it. And that's what makes this job so much fun. And I mean, I think that's what makes manual people so good. You can just palpate. I've found some articles recently when you palpate a tight muscle through palpation, it correlates with impaired proprioception. So, look at proprioceptive, what Tim was talking about. Look at vestibular. Look at every system. And I'm working on another edition of Human Locomotion because I've got time now. I want to put all this stuff together. I want to put fascial stuff together with the functional screens together with clinical biomechanics of the lower extremity. And with new knowledge based on what happens with exercise intervention. So yeah, it's complicated, and it's focusing on rate of force development, tendon strength, muscle flexibility. And again, flexibility injuries are an inverted bell curve. People who are really tight get injured, people who are really loose get injured. So I look for people in that middle zone, whether you're talking proprioception, tightness, spindle awareness, tendon resiliency. So it's a tough question, but I'm working on it.
Well, that's a great answer. And that, we always tell our athletes that when they ask us a question like that, the answer to every question is, it depends. Right.
Yeah. But we were talking last time. I hate saying that.
Right.
I've
But
always
it's the truth.
Say, let's this. Well, I do think that in the next few years, you will be able to categorize people and say this intervention is best targeted for you. I mean, even just the personalized tendon loading that I talked about at the end of this, that's hugely important. That means that people with ligamentous laxity are hurting themselves if they're doing heavy weights, and people who are really stiff aren't getting better if they're doing the lightweight, high volume protocols. So with advances in ultrasound technology, with advances in imaging, and the answers aren't in drugs. The answers are in manual care, exercise, targeted exercise. And that's
and repetitions.
Consistency.
Well, I mean, I don't think there's any better place to sum it up. I think we could keep going. I mean, what we need is like you said, the 6-hour conversation with maybe a few drinks in there or something. But Tim, anything that you want to say to close before we sign off here?
No, I'm just pissed that I haven't gotten to know you sooner, Tom. I mean, this is, you could have made my life a lot better and a lot better for a lot of athletes that I work with. And I just can't wait to dive into your work and bug the heck out of you in the future.
I'm totally fine with it, man. I've been locked in my little office in Newton for the last 40 years. I didn't get out much. So I wasn't interacting with too many people.
Right
now
on,
I got
Tom.
a little free time.
That's beautiful. Thank you so much.
Hey, thank you. Good job.
Well, if you want to see Tim and Tom speak live and in person in June in Newport Beach, California, June 13th and 14th, we'll be holding the SBRT Therapy Movement Symposium. And Tom will be speaking on exercise interventions for tendinopathy. And Tim will be speaking on numerous other topics. We'll have a few of the speakers who are on tonight. Skip George will be speaking on breath work. Dr. Mike Rentalo will be speaking on dynamic neuromuscular stabilization, along with former Lakers PT, Dr. Drew Marcos. Dr. Steve Capobianco will be speaking on interoception, and then numerous other speakers. So check out sprttherapy.com if you want more information or on any of the upcoming courses. Once again, Tom, where can they find you? You've got an amazing and really informative Instagram account as well. I think that's just Human Locomotion, or at Human Locomotion.
That's I almost forgot. It's human_locomotion for Instagram. I forgot to mention that. And then the website is humanlocomotion.com.
Great. Well, and thanks to everyone who stayed on tonight once again. If anyone has any more questions, please email us at jp@sprttherapy.com. And once again, for the SPRT Therapy team, thanks so much for joining us. Stay healthy and have a great week. Thanks, Tom. Appreciate it. Thanks, Tim.
Hey, really good seeing you, John. Good meeting you, Tim.
Thanks, everyone. Thank you, Tom. Aloha, everybody. Thanks for coming.
Thanks for joining us for today's SPRT Therapy podcast. Stay tuned for our next episode in the coming weeks, and please check us out on Instagram or on our website, sprttherapy.com, for upcoming events and discounts on live or on-demand educational courses. Have a great day and stand tall.
And my baby, I sway and not in the breeze. As I lay on the beach, watch the sunset undress as I wind down.